Hi everyone, welcome to NURS 2020 Advanced Pathophysiology and Microbiology. In this lesson, we're going to be doing pathophysiology, specifically Unit 1, the Cardiovascular Disorders. This is Part 1, Blood and Vascular Disorders. In today's lesson, we'll start off with the blood disorders, specifically looking at the various types of bleeding, the lab tests that are used in order to diagnose the various blood disorders, and then we'll focus upon the specific conditions such as hemophilia A and B, DIC or disseminated intravascular coagulation, and the various types of anemias. And then we'll move on to discuss the vascular disorders, specifically various alterations in both arterial and venous blood flow. Please remember to read this particular slide deck as well as all the other learning resources that are posted on the Blackboard shell. Let's examine the major patterns of bleeding that, as a nurse, you may be assessing. Firstly, in terms of mucosal bleeding, you get that type of bleeding from the mucosa. We're talking about, for example, the gums and the skin, when there is a reduced number of platelets. That's what we refer to as thrombocytopenia. Alternatively, the functioning of the platelets might be affected by various drugs, but we're not going to focus upon that. We're exclusively going to focus upon thrombocytopenia. How might thrombocytopenia develop? For example, bone marrow failure might result in thrombocytopenia, or as mentioned, various drugs such as aspirin can reduce the functioning of the platelets themselves. The von Willebrand factor deficiency can also lead to mucosal bleeding, but we're not going to look at that in detail. But what we will examine is what exactly occurs when you have thrombocytopenia. The clinical manifestations in the skin, for example, will be petechiae, which are pinpoint bleeds, bruises, and increased post-surgical bleeding. Remember that the platelets are required to form the platelet plugs, and when you have a deficient number of platelets, bleeding is going to occur, especially in the mucosa, which will be in the skin, in the gum and mucous membranes, as well as in the fundus of the stomach and the uterus as well. The second major pattern of bleeding that we're going to be examining is when you have deficiencies of the various coagulation factors. Hemophilia A and B are classic examples of this type of bleeding. In hemophilia A, you have a deficiency of factor 8. In hemophilia B, you have a deficiency of factor 9, and that's going to result in this type of bleeding when you have coagulation factor deficiencies. Specifically, the clinical manifestations of a deficiency of one or more coagulation factors is the hallmark clinical manifestation is the bleeding into the joints or hemarthrosis. Other examples of bleeding are into the muscle tissue, other soft tissues, even intracranial hemorrhage, and increased post-surgical bleeding. Notice here it doesn't have mucosal bleeding. Mucosal bleeding is most commonly associated with platelet deficiency or thrombocytopenia. Coagulation factor deficiency most often leads to the hallmark clinical manifestation of bleeding into the joints, hemarthrosis, or alternatively the muscles. When is the nurse supposed to examine hemostatic abnormalities? For example, when there is a genetic history of bleeding, a family history of bleeding, or if there is excessive bleeding, or if there is bleeding from multiple sides, or if there is spontaneous bleeding, that's when further evaluation of the hemostatic abnormality is warranted. Typically, this is done pre-surgically because you don't want to have the complication of post-surgical bleeding when, for example, the hemophilia A or B wasn't identified before surgery. In addition, during anticoagulation treatment, you have to know what the actual coagulation defect is or if thrombocytopenia is present in order to provide proper nursing care. So we're going to be examining the various lab tests. Specifically, the complete blood count will give you the platelet count, which might indicate thrombocytopenia, which in turn could have been deduced from mucosal bleeding. We already mentioned the platelet count specifically to determine whether there's thrombocytopenia, or the opposite of that would be thrombocytosis. We're going to focus exclusively on thrombocytopenia. The peripheral blood smear might show the shape of the various blood cells, including the red blood cells, and if they are sickle shaped, that might be an indication of sickle cell anemia. An increased bleeding time indicates a coagulation defect, and so that's a useful lab test as well. The prothrombin time, as well as the INR, as well as the activated partial thromboplastin time, all three, the PT, the INR, and the APTT tests, are all tests to evaluate both the intrinsic and extrinsic coagulation pathways. Same thing with the thrombin time, that's used to assess for the coagulation pathway, specifically the role of thrombin in the coagulation pathway. And the D-dimer assay is used to diagnose DIC, or disseminated intravascular coagulation, which we'll be examining later on. Here are the tests in a little bit more detail, along with the normal ranges. You don't need to memorize this. The normal ranges are normally provided to you, but what is important is looking at the third column over here, and that will be the situation in which the test may be abnormal. So these are sometimes used as diagnostic tests. So thrombocytopenia is diagnosed based upon the platelet count, or a significantly decreased platelet count. The bleeding time is elevated when you have thrombocytopenia, if you have abnormal platelet functions, usually due to various drugs, or if you have a deficiency of the von Willebrand factor. The prothrombin time, or PT, is used to diagnose deficiencies in various coagulation factors. Specifically, if there's a deficiency in factor 2, 5, 7, or 10, then the prothrombin time is going to be abnormal. The activated partial thromboplastin time is used to determine deficiencies of other coagulation factors, specifically, again, 2, 5, 7, 9, 10, 11, and 12. Really, the PT and the APTT tests are used to evaluate and assess for deficiencies in the various coagulation factors in both the intrinsic and extrinsic pathway. The intrinsic pathway is the much longer pathway, if you remember from your A&P, and the extrinsic pathway is the shorter pathway. So how do we remember which test is used to assess for which pathway? Well, when I learned this way back when, the analogy that we used was PT versus APTT, and it's really T versus TT. So the T stands for tennis, which is played outside, and hence is used to evaluate the extrinsic pathway. Factor 7 is part of the extrinsic pathway. Factor 2 is also factor 2, which is fibrinogen, 5, and 10 are all part of the common pathway, but factor 7, as well as factor 12 really, are part of the extrinsic pathway, and that's why you use the prothrombin time, or the PT time, where T stands for tennis. Tennis was played outside. The APTT time, or the activated partial thromboplastin time, the TT stands for table tennis or ping pong, which is played inside. Hence it's used to evaluate the intrinsic pathway, which is a much longer pathway. In the intrinsic pathway, we have factors 8, 9, 11, and 12. So the intrinsic pathway is a much longer pathway, and you would use the APTT to evaluate it. For example, in hemophilia A, which is a deficiency of factor 8, the intrinsic pathway is affected, hence the activated partial thromboplastin time is elevated. The APTT test is abnormal. Similarly, for hemophilia B, it is a deficiency of factor 9, part of the intrinsic pathway, and hence the APTT times would be elevated or increased. The PT time should be normal. The INR ratio is the international normalized ratio that is used to monitor warfarin therapy. It's not a coagulation screening test. It's actually the PT time that is standardized. You get the INR time. And lastly, fibrinogen, which is also required for the whole coagulation pathway. Let's go over some definitions before we get into the actual disorders. Anastomosis is a large area of bleeding into the skin, typically referred to as a bruise. Epistaxis is a nosebleed. Hemarthrosis is bleeding into a joint. Hematoma is bleeding into soft tissue, for example, a muscle. Hematuria is blood in the urine, could be macroscopic or microscopic, usually indicates a defect in the glomerulus. Hemoptysis is blood in the sputum when you're coughing up blood. Melena is very dark, tarry feces, typically indicative of a lower GI bleed. Menorrhagia is excessive menstrual bleeding. Petechiae are small flat hemorrhages that can range from a very small pinpoint to a few millimeters in diameter and typically do not blanch on pressure. They are very common in platelet disorders, for example, when thrombocytopenia is present. A purpura is a combination of a petechiae and/or an ecchymosis. We'll now move on to look at specific coagulation disorders. Bleeding disorders that are present due to deficiencies in coagulation factors, or a deficiency in vitamin K, or liver disease, or inappropriation activation of the coagulation cascade are all referred to as coagulation disorders. Naturally, there can be a coagulation disorders if there is a deficiency in any specific coagulation factors. For example, a deficiency in coagulation factor 8 leads to hemophilia A, while a deficiency in coagulation factor 9 leads to hemophilia B. Deficiencies in vitamin K can also lead to various coagulation disorders because vitamin K is required for the synthesis of various coagulation factors. Liver diseases can also lead to various coagulation disorders simply because the liver is the site of production of these coagulation factors. Lastly, in DIC, or disseminated intravascular coagulation, you have inappropriate activation of the coagulation cascade that can lead to the depletion of these various coagulation factors and in turn lead to the formation of excessive bleeding due to a coagulation disorder. We'll go through all that in the next little while. Specifically, we will be examining hemophilia A and B, as well as disseminated intravascular coagulation, or DIC for short. Hemophilia is the most common inherited coagulation disorder. As mentioned previously, it is due, or the etiology is a deficiency of either factor 8 or 9, and both factor 8 and 9 are part of the intrinsic pathway of coagulation, hence the intrinsic pathway of the entire coagulation cascade is affected. Consequently, in terms of a lab test, which one would be elevated in terms of the time, the PT or the APTT? It turns out is the APTT, sometimes just a PTT test, and that's because TT, remember, stands for table tennis. It's played indoors, and hence it's part of the intrinsic pathway. It's used to assess the intrinsic pathway. Factor 8 and 9 are both part of the intrinsic pathway, so in hemophilia A as well as hemophilia B, the APTT or the PTT times will be increased. And yes, both hemophilia A and B are bleeding disorders. Specifically, the etiology of hemophilia A is an X-linked recessive disorder that predominantly affects males because the gene that codes for factor 8 is found on the X chromosome. The pathogenesis is the deficiency of factor 8 simply because not enough factor 8 is being produced. The clinical manifestations of hemophilia A are actually quite variable depending upon the degree of deficiency of factor 8. The anticipated clinical manifestations are that, yes, bleeding will develop, and that might be present at the time of the delivery itself or shortly thereafter when there is excessive bleeding from circumcision, for example, in newborn boys. But the hallmark clinical manifestation of hemophilia A is spontaneous hemarthrosis, or bleeding into the joint. Individuals with hemophilia A will have easy bruising and hematoma formation even after just relatively minor trauma to that affected area. Similarly, individuals with hemophilia A and B will have severe prolonged bleeding, typically after surgery or severe lacerations. Consequently, a nurse should ask for the history of hemophilia A or B prior to any serious surgery. Hemophilia B is less common than hemophilia A and also referred to as the Christmas disease. I've forgotten why actually, but these days no one calls it Christmas disease, it's just called hemophilia B. The pathogenesis is the deficiency of factor 9, and similar to hemophilia A, the etiology is because of a genetic defect in the gene that codes for factor 9 that is also present on the X chromosome. Hence, it predominantly affects males. The clinical manifestations of hemophilia B are almost identical to hemophilia A. The hallmark clinical manifestation, remember, is bleeding into the joints or hemarthrosis. Moving along to another bleeding disorder, this time DIC or disseminated intravascular coagulation. DIC is a syndrome characterized by inappropriate intravascular activation of the coagulation cascade. In other words, yes, the coagulation cascade should be initiated when there is some sort of trauma or damage to the blood vessels, but in this case, it's the inappropriate activation of the entire coagulation cascade. As a result, thrombosis occurs, but the fact that multiple microthrombi are formed throughout the body can pose a problem. The problem is that the multiple thrombi formation throughout the body can occlude the blood vessels, leading to multi-organ infarcts or leading to a decrease in the blood flow to various organs, and that in turn can lead to multi-organ failure. So multiple microthrombi being formed all throughout the body. The formation of these microthrombi that are formed throughout the body now leads to the depletion of the platelets, and that in turn results in thrombocytopenia, and consequently after that, hemorrhage can now develop. So the etiology of DIC could be literally anything, commonly severe trauma, shock, a severe infection, malignancy, and very commonly obstetric complications. The clinical manifestations of DIC is a spectrum, as mentioned previously, of both bleeding, and the bleeding could be intracranial hemorrhage, ecchymosis, hematuria, epistaxis, or even just massive bleeding internally, as well as the formation of numerous microthrombi throughout the body. And those microthrombi formation in turn can lead to multifocal brain infarct, superficial gangrene, damage to the kidney resulting in oliguria, damage to the lungs resulting in acute respiratory distress syndrome or ARDS, as well as bleeding in the GI tract. If severe DIC can lead to multi-organ dysfunction and eventually failure and consequently death. Here's DIC in a flowchart form in terms of the pathophysiology. So there's some triggering event, for example, an obstetrical emergency or post-surgery, that leads to inappropriate activation of the coagulation cascade, which in turn leads to the formation of thousands of microthrombi as well as microemboli. That in turn leads to vascular occlusion, organ ischemia, organ dysfunction, multi-organ failure, and potentially death. The inappropriate activation of the coagulation cascade also results in the consumption of all the various coagulation factors, not just for the platelets, as previously mentioned, but of the coagulation factors themselves. And that in turn now leads to excessive bleeding because there are no coagulation factors remaining in order to stem whatever bleeding that might occur, for example, post-surgery. That leads to excessive bleeding, which in turn can result in hemorrhagic shock as well as death. That concludes the various bleeding disorders, so please focus on hemophilia A as well as B and DIC. We're now going to move on to discuss anemia. The definition of anemia is a hemoglobin concentration of less than 135 grams per liter in males or less than 120 grams per liter in females. The predisposing or risk factors for the development of anemia is a Mediterranean or Asian ancestry, and that's for the risk of developing thalassemia, or African ancestry because of the increased risk of having sickle cell anemia. If there is active bleeding, especially internal bleeding or recent blood loss, then that is also another risk factor, along with various medications, for example, anyone on chemotherapy, various immunosuppressive drugs like methotrexate, various antiretrovirals. All those are risk factors for the development of anemia. Excessive alcohol consumption and lead exposure, although that might be rare these days, are also risk factors, along with various forms of diets. So a diet low in green leafy vegetables can lead to folate deficiency, that in turn can result in megaloblastic anemia. A vegan diet is a diet that is typically deficient in vitamin B12, and that can also lead to megaloblastic anemia. A tea and toast diet, which is a euphemism for a diet of an individual living in severe poverty, that would be typically deficient in iron because of the deficiency in fruits and vegetables, and that can lead to iron deficiency anemia. What are the clinical manifestations of anemia? Well, the clinical manifestations are rather non-specific if you look at it, right? So trying to distinguish the various forms of anemia just based upon the clinical manifestations is not possible, although they are general in nature. So what are the clinical manifestations? Fatigue, weakness, exercise intolerance, syncope of the feeling of dizziness, dyspnea, headaches, palpitation, tinnitus or ringing in the ears, cold intolerance, and overall difficulty with mentation or just thinking or concentration. As you can see, those are still rather non-specific clinical manifestations, but when you put them all together, that is indication of anemia. In terms of the cardiovascular system, tachycardia and postural hypertension does develop. Tachycardia as a compensatory response to increasing the blood flow, and postural hypertension as well. In terms of the GI system, hepatosplenomegaly can result, especially if there is thalassemia or chronic hemolysis of the red blood cells. In terms of skin assessment, there's pallor, jaundice if it's the hemolytic form of anemia, petechiae and purpura if there is some coexisting bleeding disorder as well, for example in DIC. In terms of the neurological manifestations, they can be numbness, paresthesia, ataxia. All of these would be common if there is severe vitamin B12 deficiency that leads to a megaloblastic form of anemia. So here are the various types of anemia that we'll be examining. We'll start off with the most common form of anemia, which is iron deficiency anemia, and then we'll examine anemia of chronic kidney disease, given the fact that chronic kidney disease is so very prevalent. We'll move on to sickle cell anemia, thalassemia, aplastic anemia, anemia related to vitamin B12 or folate deficiency. That will be a form of megaloblastic anemia, as opposed to iron deficiency anemia, which is a form of microcytic anemia. And we'll close off with hemolytic disease of the newborn. This particular table shows you the classification of the various forms of anemia. Initially, you would look at the red blood cell appearance. This is typically done under a microscope. If the cells are small, we say it's a microcytic form of anemia. If the cells are large, it's a macrocytic form of anemia, or if they are normal sized. Microcytic forms of anemia can also be determined based upon the MCV. That's a lab test. The MCV, or mean corpuscular volume, will tell you, is the red blood cell smaller than normal or is it larger than normal? A low MCV indicates a smaller than normal red blood cell, in other words, a microcytic form of anemia. If it's larger than normal, the red blood cells called macrocytes, and we call it macrocytic anemia, the MCV is going to be high, or if it's a normal size, it'll have a normal MCV. Examples of microcytic anemia, in other words, having low MCV, would be iron deficiency anemia, thalassemia, anemia of chronic kidney disease, including anemia of chronic diseases in general, and we're not going to talk about ceroblastic anemia. Megaloblastic anemia or macrocytic anemia, that would be due to vitamin B12 or folate deficiency where the MCV is high. We're not going to look at the other forms that can lead to macrocytic anemia. Lastly, you can still have anemia with normal sized red blood cells. For example, if you have acute blood loss, your red blood cell sizes has not changed, so you're going to have a normal MCV, yet you're going to have anemia because your hemoglobin content has decreased, which is the definition of anemia. Here you notice the anemia of chronic kidney disease can have a normal MCV or a low MCV, so that's a bit iffy, so to speak. But the more characteristic features of microcytic anemia would be if it were iron deficiency anemia, or if it were vitamin B12 or folate deficiency, that would lead to megaloblastic anemia. We're not going to look at the other forms of anemia that are listed over here, just the ones that were seen on the previous slide. As mentioned, microcytic anemia is when the red blood cells are smaller than normal. In other words, the mean corpuscular volume, or MCV, is less than 80 fluid liters. The types of microcytic anemia are iron deficiency anemia, which is the most common form of anemia, anemia of chronic kidney disease, and thalassemia. Thalassemia also leads to microcytic anemia, a form of microcytic anemia. Let's examine iron deficiency anemia first. It is, as mentioned, the most common cause of anemia, at least in North America. The etiology could be several. It could be due to an increased demand for iron. Remember, iron is required for the synthesis of hemoglobin. If you have an increased demand for iron, for example, in pregnancy, now you're going to develop iron deficiency anemia. So pregnant women, it's very common for pregnant women to have a form of iron deficiency anemia. However, usually the most common cause or form of iron deficiency anemia is when there is a decreased supply of iron. These days, it's really hard to get sufficient iron content in the diet because of a awful North American diet. So typically, iron deficiency anemia develops because of dietary deficiencies, or less commonly absorption imbalances or malabsorption syndromes over there. But if you don't have a diet that is rich in fruits and vegetables, it's going to be really hard to get sufficient amounts of iron. The last probable cause of iron deficiency anemia is because of increased losses due to hemorrhage, for example, amenorrhagia or excessive menstrual bleeding, abnormal postmenopausal uterine bleeding, for example, if there is a GI bleed, if there is peptic ulcer disease or bleeding in the stomach, if there is a GI cancer, for example, colon cancer that causes bleeding in the stools, all that can lead to iron deficiency anemia because you're losing the iron in the form of hemoglobin when you lose the blood. Lastly, hemolysis can also lead to iron deficiency anemia. When the red blood cells rupture, you lose the hemoglobin. That can not only cause kidney damage, but it can also lead to the loss of iron and hence iron deficiency anemia, although that is still rather rare. More common causes of iron deficiency anemia are because of increased losses due to hemorrhage and a decreased supply of iron. Anemia of chronic kidney disease, the pathogenesis is multifactorial. As you know, from ENP, the kidneys produces the hormone erythropoietin, which is required for the production of the red blood cells in the red bone marrow. And now when you have the kidneys being damaged for whatever reasons, most commonly because of poor glycemic control in diabetes mellitus, now insufficient amounts of EPO are going to be secreted, and that can lead to anemia of chronic kidney disease. In addition, when chronic kidney disease is present, we're not going to go through this in any detail, but iron utilization is also impaired. And when you can't utilize the iron and transport the iron properly, then you're going to end up with anemia. So that's another cause of anemia of chronic kidney disease. And finally, in chronic kidney disease, there are usually other comorbidities as well, and there's overall increased inflammation, and there might be an increased risk of hemolysis as well, whereby you're going to lose the hemoglobin, you're going to lose the iron. Let's now discuss sickle cell anemia. Sickle cell anemia is an autosomal recessive genetic disorder of the hemoglobin synthesis. The sickle cell hemoglobin that is produced instead of normal hemoglobin is not stable and insoluble, especially when oxygen concentration in plasma is low. The sickle cells that result as a consequence of low oxygen concentration are much stiffer than normal red blood cells. And if you remember, the capillaries are actually smaller than the diameter of a red blood cells, and that's why the red blood cells are biconcave, because they have to fold upon itself in order to squeeze through a capillary. But these sickle cells, because of the sickle cell hemoglobin, are unstable, and they are very rigid actually, and consequently they cannot deform in order to squeeze through those capillaries. As a result, vascular occlusion occurs, and that in turn causes what is referred to as vaso-occlusive crisis, leading to tissue ischemia. But remember, these cells become sickled only when oxygen concentration drops well below normal. Consequently, the treatment for sickle cell anemia, and actually prophylactic treatment, is oxygen therapy. You do not want the oxygen concentration to drop much below normal, otherwise the cells will start to sickle, leading to the vaso-occlusive crisis, which are very, very painful because of the tissue ischemia. So sickle cell anemia is a severe form of anemia that results in red blood cells of different shapes and sizes. The hallmark clinical manifestation is the vaso-occlusive crisis. Here's it in schematic form. So you have a red blood cell that contains HbS, which is the sickle cell form of hemoglobin. And in the presence of low oxygen concentration, the red blood cells sickle, they become elongated, rigid, consequently they cannot squeeze through the capillary. That in turn leads to occlusion of the capillaries and smaller arteries, leading to tissue ischemia and infarction. The clinical manifestations would be severe pain and loss of function, for example, for that particular limb itself. In addition, the sickle cell hemoglobin, as mentioned, is not very stable. Consequently, the red blood cells themselves become increasingly prone to hemolysis. And when the red blood cells, the sickled red blood cells, or even the normal red blood cells, normal in the sense that they have not sickled, but abnormal in the sense that they do contain sickle cell hemoglobin, when they are recycled in the spleen, there's increased risk of hemolysis. That in turn leads to a decreased red blood cell count. Consequently, it results in severe anemia. In addition, as we'll see, the increased hemolysis later on also leads to increased risk of jaundice formation because you're producing more bilirubin. Let's move on to thalassemia. Thalassemia is another genetic defect, but this time in terms of the production of the alpha or beta chains of normal hemoglobin. Normal hemoglobin is alpha 2 beta 2, but in thalassemia, either the alpha chain or the beta chain of hemoglobin cannot be produced in adequate quantities. It is a genetic defect because there's a gene that controls the formation of either the alpha or the beta chain. And there are various forms of thalassemia, alpha and beta thalassemia, that occurs because of a defect in, or the lack of ability of producing the alpha or beta chain of hemoglobin. The resulting imbalance of the alpha and beta chains leads to an increased risk of hemolysis in the spleen or the bone marrow. So instead of alpha 2 beta 2 for normal hemoglobin, it could be, if you have alpha thalassemia, you can produce enough of the alpha chain. It could be alpha 1 beta 3, or even just beta 4 if you can't produce any of the alpha chains. Similarly, for beta thalassemia, it could be alpha 3 beta 1 or even alpha 4 if you can't produce any of the beta chains of hemoglobin. The clinical manifestations of thalassemia depend upon whether it is alpha or beta thalassemia, in other words, whether the alpha or beta gene is affected, and the number of alleles affected. So the number of alleles affected in turn will affect the amount of alpha and beta chains that can be produced. The common features of both forms of thalassemia, whether it is alpha or beta thalassemia, is that the severity increases with the increasing number of alleles involved, as already mentioned. So the fewer alpha or beta chains that can be produced, the more severe the form of thalassemia is, right? So if you can produce some of the alpha or some of the beta, it's not as severe as opposed to if you can produce none of the alpha or none of the beta chains. Thalassemia itself is a form of microcytic anemia whereby the MCV values, mean corpuscular volume, if you remember, values are much below normal, so that's why there's micro meaning small, that's why it's a form of microcytic anemia, and hyperchromic because overall hemoglobin concentration is lower. So here's it in schematic form in terms of beta thalassemia. So in beta thalassemia, you're not able to produce enough of the beta chain, so you have the alpha chain excess. That makes the red blood cells more unstable, resulting in precipitation, increased risk of hemolysis, and finally anemia. The excess alpha relative to the beta chain also leads to the abnormal hemoglobin synthesis. So instead of alpha 2 beta 2, it could be alpha 3 beta 1 or even alpha 4 hemoglobin, and that is an abnormal form of hemoglobin. That in turn leads to decreased erythropoiesis because the body doesn't want abnormal forms of hemoglobin, leading to anemia. The anemia itself in turn triggers the increased production of erythropoietin because the body realizes it doesn't have enough red blood cells, and so you have an increased production of erythropoietin from the kidneys or EPO, and this produces a vicious cycle because yes, you want to produce more red blood cells, but you can only produce, or you can mainly produce, the alpha chains, and that perpetuates the cycle. In addition, as EPO concentration increases, bone marrow activity increases, iron absorption increases, and that can lead to other complications of thalassemia, specifically beta thalassemia, leading to iron overload, liver toxicity, and various bone deformities, all the way up to bone marrow failure itself. Moving along to aplastic anemia. Aplastic anemia is a stem cell disorder characterized by an absolute decrease in hematopoietic tissue in the bone marrow. So instead of normal red bone marrow, it's now replaced by fat, resulting in fatty marrow or yellow marrow. And in turn, you can produce not only red blood cells, but really any blood cell. And that leads to a condition known as pancytopenia. Pan means everything, cyto is cell, penia is poverty, so a lack of all blood cells. Consequently, you have a reduction in the absolute number of red blood cells, anemia, white blood cells, leukopenia, which in turn leads to increased risk of infections, especially opportunistic infection, and a decreased platelet count, thrombocytopenia, that leads to various bleeding disorders, especially mucosal bleeding. The etiology of aplastic anemia is varied. It could be various toxic insults, toxic drugs, radiation, or it could be an autoimmune injury as well. There's really no treatment other than a bone marrow replacement. Moving along to anemia related to folate or vitamin B12 deficiency. In both these cases, folate or vitamin B12 deficiency results in a form of megaloblastic anemia. The red blood cells are larger than normal, consequently MCV or mean corpuscular volume is enlarged. The reason why you need folate and vitamin B12 is for DNA synthesis, and red blood cells are produced all the time, consequently you need vitamin B12 and folate. A disruption in DNA synthesis as a consequence of folate or vitamin B12 deficiency leads to megaloblastic anemia. I also want to mention pernicious anemia. Pernicious anemia is a specific form of anemia that develops due to a lack of intrinsic factor. Intrinsic factor is produced in the stomach, and intrinsic factor is required in order to absorb vitamin B12 from the diet in the GI tract. And when you have a lack of intrinsic factor, for example, because of an autoimmune destruction of the gastric mucosa, that leads to a vitamin B12 deficiency because you cannot absorb it, and that leads to this condition known as pernicious anemia. So in megaloblastic anemia, you have a low red blood cell count, that's anemia, but you also have low white blood cell and platelet counts because, remember, this is all based on lack of DNA synthesis. You require folate and vitamin B12, adequate amounts of folate and vitamin B12 in order to get DNA replication. The treatment is to replace folate or vitamin B12, so you're going to require supplementation. The last form of anemia that we're going to discuss is hemolytic disease of the newborn. Hemolytic disease of the newborn only affects Rho-negative mothers. So remember the ABO blood group. If you have A antigens on your red blood cells, you're blood type A. If you have B, you're blood type B. If you have neither A nor B antigens on the surface of your red blood cells, you're blood type O. If you have both, you have blood type AB. But let's not also forget the Rho antigen. So about 90% of us have the Rho antigen, so we are Rho positive. Hemolytic disease of the newborn, as mentioned, only affects Rho negative mothers. In other words, mothers whose red blood cells don't have the Rho antigen. And so if a mother is Rho negative but now has a fetus that is Rho positive, that can pose a problem. The reason being is that the fetal red blood cells can cross the placenta and move into the maternal circulation, and now the mother's immune system will recognize the foreign Rho antigen. It's foreign because the mother has never seen a Rho antigen, and mount an immune response that will ultimately cause the destruction of any red blood cell that contains a Rho antigen, hemolysis in other words. Usually this is not a problem in the first pregnancy, but if the mother has a second fetus who's also Rho positive, that can pose a big problem because now the mother has antibodies against the Rho antigen, and those antibodies can cross the placenta and cause destruction and hemolysis of the fetal red blood cells, ultimately resulting in either stillbirth or severe birth defects that ultimately is typically not viable for the fetus itself. So that's the big problem. If the mother is Rho positive, then obviously this is not an issue because the mother is not going to be able to produce antibodies against the Rho antigen because her red blood cells have the Rho antigen. So the treatment of hemolytic disease of the newborn is really non-existent. The treatment is prophylactic over there because you want to prevent the maternal immune system from reacting to those Rho antigen. So the prophylactic treatment is a standard dose of anti-Rho immunoglobulin called RhoGAM that is given to all mothers who are Rho negative before delivery. We're now going to switch gears and discuss the vascular disorders, starting with acute limb ischemia. Acute limb ischemia occurs as a consequence of an acute occlusion of a peripheral artery that ultimately threatens the viability of that particular limb. Usually the lower extremities are affected more than the upper extremities, and the thighs more than the trunk itself. So the femoral popliteal arteries are more affected compared to the aorta or the iliac artery. The etiology is a embolism or a thrombus that forms within the artery itself. The emboli could form as a consequence of various arrhythmias, for example, atrial fibrillation or valvular heart diseases. The thrombus could form as a result of a rupture of atherosclerotic plaque or trauma to the limb itself. The classical clinical manifestation of acute limb ischemia are the 6 P's: pain, pallor, paresthesia, paralysis, pallor or the limb feeling cold, and pulselessness. All these can be easily explained. Pain because of the ischemia, pallor because of the lack of blood flow, paresthesia because of the lack of blood flow to the peripheral nerves. Usually you have the light touch sensation disappearing first. Paralysis is actually the most important clinical manifestation, but that usually only develops later on and indicates impending loss of the limb itself. Pallor because of the lack of blood flow to the limb, and pulselessness as well. The pulselessness helps to determine the site of the occlusion. So if the popliteal pulse can be assessed as opposed to the pedal pulse, then that helps the nurse to determine the site of the occlusion. Peripheral arterial disease, or PAD for short, is when there is chronic ischemia due to an inadequate blood supply to meet the metabolic needs of the limbs during walking. We refer to that as claudication. However, if the pain occurs at rest, that would mean that it is a critical form of ischemia that can lead to acute limb ischemia. The etiology of PAD is atherosclerosis, whereby the atherosclerotic plaque reduces the diameter of the lumen of the arteries, thereby reducing the blood flow. The modifiable risk factors are what the nurse should focus upon when providing health education, include smoking, diabetes mellitus, hyperlipidemia, hypertension, obesity, as well as a sedentary lifestyle. The non-modifiable risk factors which cannot be changed include age, prior medical history, family medical history of peripheral arterial disease, coronary artery disease, cerebrovascular disease, or cardiovascular disease. The clinical manifestation of PAD include claudication, as mentioned, that is pain with exertion. The pain usually occurs in the calves and the hamstrings, but it is relieved by rest. So if the patient or client rests for about 5 minutes, the pain should be significantly reduced or disappear. But if they start walking again, the pain should come back. It should be reproducible. That is a hallmark clinical manifestation, claudication of peripheral arterial disease. Another form of a vascular disorder that we're going to be discussing is aortic dissection. Aortic dissection is when there is a tear in the tunica intima that allows blood to dissect through it into the tunica media. If you remember your A&P, there are 3 layers to especially the larger blood vessels: the tunica intima, which is the endothelium, the tunica media, which is the smooth muscle, and the tunica externa, which is the connective tissue on the outside. Here we have the tear in the endothelium, allowing blood to pool between the tunica intima and the tunica media, between the endothelium and the smooth muscle. The etiology is typically hypertension, uncontrolled hypertension. In terms of the epidemiology, you will see that males are more likely to be affected than females, but age is a non-modifiable risk factor as well. The clinical manifestation of aortic dissection, which is a medical emergency, is a sudden onset of a tearing chest pain or pain that radiates distally to between the scapulae. In other words, it's a form of referred pain that goes towards the back of the body. The aortic dissection in turn can cause bleeding into the pleura, resulting in hemoptysis of coughing up of blood, dyspnea or difficulty breathing, as well as shock when you have blood pooling into the retroperitoneum or the pericardium itself. If blood starts pooling into the pericardium, this is, remember, from the aortic dissection, that can cause cardiac tamponade, whereby so much blood pools around the heart that the heart is no longer able to effectively contract. In addition, you have reduced blood flow to the brain that can cause syncope or fainting spells. Moving along to aneurysm. Aneurysm is a localized dilatation of an artery whereby the diameter of the artery, whatever artery that we're looking at, increases by more than 1.5 of its normal diameter. In terms for the abdominal aorta, we have a specific number. If the abdominal aorta, the diameter of the abdominal aorta is greater than 3 centimeters, then we have an abdominal aortic aneurysm, or AAA for short. A couple more definitions. A true aneurysm involves all three layers, so both the tunica intima, media, as well as the tunica adventitia are affected, so you have complete dilatation of all three layers. A false aneurysm is when there's a breach in the tunica intima or the media that allows blood to collect between the media and the adventitia. Notice that's different from a dissecting aneurysm. Here, it's a false aneurysm is the breach between the media and the adventitia. Dissecting aneurysm is between the intima and the media. The problem with aneurysms is that, or complications to be more precise, is that they can rupture, thrombose, embolize, erode, or fistulize, right? So if it ruptures, we know we're going to have severe bleeding. If a thrombus forms, that in turn can be very problematic. That can cause, depending upon the location, an infarct at that location. If it embolizes, it can transport to another area of the body, thereby causing a stroke or a myocardial infarction or a pulmonary embolism. And the erode and fistulize are other complications that need to be avoided as well. In terms of the classification of aneurysms, they are classified based upon their shape. So if it is the full circumference is affected, we call it a fusiform aneurysm. If only one part of the wall is affected, not the full circumference, but say half the circle, half the circumference, then we call it a saccular aneurysm. In addition, the aneurysms are classified based upon their location. So if it is in the thoracic aorta, we call it a thoracic aortic aneurysm, or even more commonly, if it is in the abdominal aorta, we call it an abdominal aortic aneurysm, or AAA for short. Risk factors, modifiable, include smoking and hypertension. Non-modifiable are age as well as sex. So males are more commonly affected compared to female. In terms of clinical manifestation, it might surprise you to know that 75% of all aneurysms are asymptomatic. And if they don't grow, if they don't rupture, thrombose, embolize, erode, or fistulize, then they can remain asymptomatic the entire life. Symptoms only develop when there is an acute expansion or rupture of the aneurysm itself. Let's discuss abdominal aortic aneurysms, or AAA for short, in more detail. A AAA could be asymptomatic, but when there is an acute expansion, so in other words, if the diameter of the abdominal aorta is greater than 3 centimeters, or if the aneurysm ruptures, then that can pose severe issues. It can be life-threatening, in fact. It's a medical emergency. The clinical manifestation of the acute expansion or rupture of a AAA includes syncope, whereby you have reduced blood flow to the brain, pain in the chest, in the abdominal region. It could be referred to the back or the flank region. Hypotension, that if severe can lead to shock. In addition, there could be a palpable pulsatile mass above the umbilicus, right where the abdominal aorta is located. The rupture of the abdominal or the expansion of the AAA can lead to airway or esophageal obstruction. And lastly, if there is actual rupture, blood can pool in the lungs, leading to hemoptysis, or in the GI tract, leading to hematemesis, or the vomiting of blood. Now we'll move along to discuss atherosclerosis, which is the main risk factor. In fact, it is the main etiology for coronary artery disease. We saw it was an etiology for peripheral arterial disease as well. Atherosclerosis is the hardening of the arteries. The modifiable risk factors are hypertension, diabetes mellitus, smoking, and dyslipidemia, or an elevated LDL concentration. The pathogenesis of atherosclerosis is that you have some initial endothelial injury. What exactly causes that is really unknown. It could be the deposition of LDL, excessive LDL, due to dyslipidemia. But whatever the case is, the endothelial injury leads to inflammation, and then the LDL metabolism helps to promote hyperplasia and formation of the fibrous cap over the lipid core, resulting in an atherosclerotic plaque. So first you have injury. What exactly causes the injury is not really important, and it's mostly unknown. But then you have inflammation, and because dyslipidemia is present, you have alterations in LDL metabolism that promote hyperplasia of the endothelium. That causes in addition, the alteration in the LDL metabolism causes deposition of fatty streaks. You have a lipid core, and that's ultimately covered by this fibrous cap due to the hyperplasia of the endothelium. All that and it's best seen when we look at the diagram next, is called a atherosclerotic plaque. So the injury ultimately leads to the formation of the atherosclerotic plaque that in turn causes a narrowing of the lumen of that particular blood vessel. In fact, the key issue with atherosclerosis is whether a stable or unstable plaque is formed. A stable plaque has a thick fibrous cap, whereas an unstable plaque is vulnerable because the fibrous cap is not very robust. We say it's vulnerable because the plaque itself can rupture, and the rupture of the plaque leads to thrombosis. So if you have atherosclerotic plaque causing a reduction or stenosis of, say, 50% of the artery, that in of itself might not be too bad because there's usually collateral circulation and so forth. Blood can take an alternate route if that particular blood vessel has been narrowed down by 50%. But the problem is if the plaque is unstable, typically because the fibrous cap is unstable or thin, then the rupture of the plaque can cause the formation of a thrombus. And now when a thrombus forms, you can have complete occlusion of an artery. And if that occurs in a coronary blood vessel, for example, that can lead to a myocardial infarction, or MI for short. So a rupture of the plaque is what is the dreaded complication of atherosclerosis because it leads to thrombosis or an embolus formation. And yes, the lumen gets even more narrowed down, and the wall itself of the blood vessel can become weaker, leading to an increased risk of aneurysm formation. Here's a diagram that explains atherosclerosis. You have some chronic endothelial injury due to hyperlipidemia, hypertension, smoking, various other toxins, etc., or even an autoimmune reaction. That in turn causes endothelial dysfunction, whereby you have increased permeability, a recruitment of white blood cells. That causes smooth muscle hyperplasia. That in turn causes more immune system activation. Fatty streaks start getting deposited. You start forming a lipid core, and you have more smooth muscle and macrophage hyperplasia. Ultimately, the macrophages are there to engulf the fatty streaks, and that causes deposition or these foamy cells. These are macrophages that have ingested all the fat. So now you have the formation of a lipid core, and it is ultimately capped as well. So you have this fibrous cap. The key thing of atherosclerotic plaque, which is also referred to as a fibrofatty atheroma, is how thick is the cap over there. The thicker the cap is, the more stable it is, the less likely it is to rupture and form a thrombus or embolus. Whereas if it's a thin cap, that makes it vulnerable, it's more easily ruptured. Ultimately, a thrombus can form a ruptured plaque, and that can completely occlude the blood vessel, resulting in an infarct. Let's switch gears and now talk about venous thromboembolism. Venous thromboembolism is when a thrombus forms in a superficial or deep vein, and then you have the subsequent inflammatory response. Example of venous thromboembolism include deep vein thrombosis, DVT, or a pulmonary embolism, PE for short. What is the etiology of a venous thromboembolism? It could be endothelial damage, it could be states that promote venous stasis, for example, post-MI, or in heart failure, stroke, or post-operative. In all those states, venous blood flow becomes very sluggish, you have venous stasis, and that can lead to the formation of a thrombus or an embolus. Other etiologies include various conditions that lead to an increased risk of activation of the coagulation cascade, in other words, hypercoagulable states that develop after surgery, after trauma, when malignancies are present, or if there is prolonged immobilization, especially for DVT. If you are in traction, for example, there's an increased risk of DVT. Oral contraceptive pill use, OCP use, has been shown to increase the risk of DVT as well as PE as well. HRT is hormone replacement therapy. That also increases the risk of both DVT and PE. And lastly, pregnancy. All of those lead to what we refer to as a hypercoagulable state. The clinical manifestations of DVT include the unilateral leg edema. So the thrombus or the embolus typically forms only on one limb, not both limbs. So unilateral leg edema, as the blood vessel becomes occluded, that increases the hydrostatic pressure in that particular vein, and that causes increased exudation of fluid out of the blood vessel, resulting in unilateral leg edema. Alternatively, another way to explain the leg edema is that venous blood flow back from the leg is reduced, and that in turn causes increased hydrostatic pressure in the venous system, causing leg edema. The other classical clinical manifestation of deep vein thrombosis include erythema, as the blood starts pooling in the vein in the lower extremity, warmth, and tenderness. So in terms of the assessment of DVT, you would measure the calf circumference of both legs. If one is significantly larger than the other and there is erythema, warmth, and tenderness, then that could increase the suspicion of a DVT, a unilateral DVT. Ultimately, the DVT is diagnosed using a Doppler ultrasound to directly measure blood flow in that particular limb itself. The complication of venous thromboembolism includes a development of acute pulmonary embolism, which is life-threatening. We will discuss PEs in more detail when we do the respiratory disorders. The treatment for DVT and venous thromboembolism in general is various anticoagulants such as low molecular weight heparin, unfractionated heparin, direct thrombin inhibitors such as dabigatran, direct factor 10 inhibitors such as oxybaxan, and various thrombolytic drugs such as tissue plasminogen activator. Now, which one is exactly used will depend upon the physician's determination. Chronic venous insufficiency is far more common than venous thromboembolism, and it refers to a wide spectrum of various chronic venous diseases with advancing symptoms of edema. Here are the clinical manifestations of chronic venous insufficiency: edema, various skin changes, varicosities, and ultimately leg ulcers development. 65% of all North American adults will eventually develop some form of venous insufficiency. The etiology of chronic venous insufficiency is the valves become incompetent. Alternatively, for other reasons, the venous blood flow is obstructed. Risk factors for chronic venous insufficiency include non-modifiable ones include age, and modifiable ones include prolonged standing, pregnancy, and obesity. The clinical manifestations of chronic venous insufficiency are pain, whereby you have this feeling of fullness, tightness, or aching pain that is usually worse at the end of the day after standing for prolonged periods of time. Ankle or calf edema as blood starts pooling in the lower extremity, and that's relieved by elevating the feet. Skin changes as all the blood is pooling there constantly. Examples of skin changes include pruritus, eczema, status dermatitis as the skin slowly starts to break down when so much blood is being pooled in the lower extremity, especially around the ankle region, and the brownish hyperpigmentation. More melanin gets deposited for reasons that we're not going to go through over there. Ultimately, chronic venous insufficiency can also lead to ulceration. This is the end result of all the skin changes that we previously described. And yes, varicose vein formation as well. In fact, that is when the valves become incompetent, varicose veins typically develop first, and in turn that leads to this chronic venous insufficiency and all the other complications that we were just describing. The treatment for chronic venous insufficiency are compression stockings as well as ambulation. You don't want to be sitting for too long because that in turn is bad. Neither is prolonged standing as well. And periodic rest and elevation. So walk a little, rest a little, walk a little, rest a little. That brings us to the end of part 1 of Unit 1. So in summary, please remember to learn the pathophysiology, which is the etiology, the modifiable risk factors. You should know the non-modifiable ones as well, but it's really focus upon the modifiable risk factors because that can be addressed in the nurse's health education. The pathogenesis should not be the focus, although you do need to know the pathogenesis, but only briefly. You should be able to describe the pathogenesis of most diseases in 2 or 3 lines itself. Most importantly, the nurse should focus upon the clinical manifestation because you have to assess for. Unless you know what the anticipated clinical manifestations are, it's very difficult to assess for them. So please review the pathophysiology, which is the etiology, the modifiable risk factors, briefly the pathogenesis, and most importantly, the clinical manifestation of the various diseases, disorders, and conditions that we covered in this slideshow, which is only part 1. Part 2 and 3 are coming up. But also refer to the learning outcomes of Unit 1 in the syllabus. Remember, I do not cover all the learning outcomes. It is still your responsibility to cover all the learning outcomes that are listed in the syllabus. You will only be assessed upon the diseases, conditions, or disorders that are listed in the learning outcomes. So when you're reading the textbook, if you come across other diseases, disorders that are not part of our learning outcomes, you can safely ignore it. Please remember to contact me by email at avinashnathani@georgiancollege.ca if you require any clarification or assistance whatsoever. Our next lesson is going to be on part 2 of the blood and cardiovascular disorders. We're going to focus upon the heart disorders. See you then. Thanks. Bye.